Welcome to Ageless and Outrageous, your favorite podcast about how to age amazingly. I'm urogynecologist and hormone and sexual health expert, Dr. Kristen Jackson. Every week, I share my over 25 years' experience to guide both men and women as they age. Listen as I discuss a variety of topics, including hormone optimization, pelvic floor health, maintaining a vibrant sex life, weight gain issues, and skin, hair, and body changes as we age. It's happening to all of us, so listen for some solid scientific knowledge on how to handle these changes. Tune in for a dose of laughter, knowledge, and an honest perspective on the incredible adventure of growing older. Sex after cancer treatment, any type of cancer treatment, can cause women to undergo a lot of different types of changes. And with a huge number of women not only treating their cancers, but surviving for many years afterwards, this is an important discussion to have. I see so many women after their treatment for breast cancer, uterine cancer, cervical cancer, colon cancer, the list goes on. They've survived their surgery, they've undergone chemotherapy or radiation or whatever treatment might be necessary after surgery, and now they're cancer-free. And they're looking at many years of their life left after their initial fear of, am I going to survive? The cancer has passed, and they're now looking at what is the quality of the rest of my life in terms of sexual health. Sexual changes after cancer treatment obviously can depend on the type of cancer you've had, but most changes occur in one of three categories. The most obvious might be physical changes, depending on where your cancer was located. You may have undergone a lumpectomy or a mastectomy for breast cancer. You may have undergone a hysterectomy or had your ovaries removed for a uterine or ovarian cancer. You may have had a colon resection, leaving you with a colostomy if you've had colon cancer. Some women require radiation therapy, which generally leads to tight, scarred, or less flexible tissue in the area that was radiated. It can also lead to pain in the pelvis and the vagina. Some women require chemotherapy or ongoing treatments with tamoxifen or aromatase inhibitors. Chemotherapy can initially lead to sickness and hair loss and joint and bone pain, but it can also induce an early menopause, which will be much more severe than a natural menopause. So these women will be facing more intense hot flashes and night sweats, more intense vaginal dryness and pain, more intense brain and memory changes, and more intense exhaustion. Psychological changes, while not as overt, can be just as important. A cancer diagnosis can cause anxiety, depression, and sleep disturbances. There can be changes in your body image after surgery. And it's so important to realize that addressing changes in our body image is not about vanity. Our body is intimately tied to who we are and what we project into the world. So whether the change is visible to the world or not, so for example, if you've had a mastectomy, it might not be noticeable to the general population if you use implants. Or if you have a colostomy bag, most people don't see that because it's covered with your clothing. But the patient still knows it's there and may be forever changed. And her relationship with her body has changed as well. Now, sometimes this is for the good. So if you're a woman who needed a mastectomy and got implants, you may feel that your figure has improved. But for many women, the scars or the implants are just a constant reminder of their cancer diagnosis. Finally, there can be intimate relationship changes. Cancer often brings out the negatives or the stresses that already exist in our relationships. It magnifies them because both partners are facing fear and uncertainty. Often, at least for a time, couples go from being lovers to being a patient and a caregiver. And it can be really hard to go back from that to being equal, intimate partners. Communication can be difficult. One partner may not want to touch the breasts after surgery for fear of causing their partner pain. But the woman may interpret that as, well, now my partner is no longer aroused by me or even turned off because I've had this surgery. So fear of harming the cancer patient can be interpreted as lack of interest. So we know that cancer changes people's lives in a multitude of ways, and all of these sexual ways are just another area that's important to address. But very often, a lot of these female sexual changes after cancer don't even get discussed before cancer treatment. I attended a urology visit with a male family member who needed prostate surgery. And it's very well known that prostate surgery can cause post op issues both with male incontinence and sexual performance. There can be erectile dysfunction or retrograde ejaculation. And all of these risks were openly discussed by the urologist. And a baseline of where the patient was in terms of erectile strength and frequency was reviewed. So this was all discussed and documented with the male patient before any surgery or treatment was started. Then, after his surgery, his sexual function was again reviewed, meaning they asked him, are you noticing any sexual changes? Are you noticing any change to your erection? Are you noticing any incontinence? And then they talked about if those symptoms happened, what treatments do we have that we can offer? I think this really shows the value we place on male sexual function in our medical field and our society in general. It's important. Surgery might alter it. So let's talk about it. And if it happens, let's fix it. I've also attended oncology visits with a patient who's had breast cancer. And of course, I've cared for thousands of patients who've had breast cancer treatments. Sexual function after breast cancer surgery is rarely discussed at the time of diagnosis, nor are the many changes that treatments, surgery, chemotherapy, radiation, and drugs can bring about. If these sexual issues are discussed, it's usually done after treatment. And very often, the oncologist is either not offering solutions, or maybe the oncologists themselves are not even familiar with what's available. And I am not at all putting the blame on the oncologists. Female sexual pleasure just doesn't have a high worth in traditional medical training. It's not explicitly taught in medical school, nor in residency, when in reality, I think it should be a huge part of OBGYN training and internal medicine training and oncology training. I mean, when I think back about what was my formal training about women's sexual issues, I would say slim to none. We learned about the sexual response, but we did not dive deeply into how do effects treat it. They were listed in a list of side effects. These drugs can cause negative sexual side effects, and then move on to the next topic. So I think even though there are so many treatments and solutions out there, a lot of oncologists are just so narrow and staying in their lane. They're thinking, we don't want to do anything that could cause recurrence of this cancer, even if we have data showing that we have solutions that will not cause recurrence of the cancer. We're just going to do nothing. And I think that is such a theme in women's health. Let's just do nothing for fear of causing harm, when in reality, doing nothing is what's causing harm. Not treating is actually causing harm. I've also had patients say to me, I would rather hear about all of the risks of the different treatment options for my sexual health and get to make my own decision. Like, even if I knew a treatment could improve my sexual life, but it also increases my risk of my breast cancer coming back, for example, by 3%, I'm going to do it anyway because I would rather have a happy, pain-free, satisfying sexual life, and I'll take the small increased chance of recurrent cancer. I can monitor for that. So I think patient choice is also a big part of it. And I think we need to be presenting these options to patients so that doing nothing is no longer an option. I think most physicians are highly intelligent and highly trained individuals. We know they possess a huge wealth of knowledge about their specialty. But if female sexual improvement is not taught in med school or residency, then of course, physicians are not thinking of it in their evaluation, which means as a physician, you really need to seek out this additional information on your own. And many physicians just don't necessarily have the time or desire to do so. But for those who do, they will find that there is tons of information about it. So let me go through some of the most common sexual changes after cancer treatment. They are vaginal dryness, no libido, and pain with sex. Vaginal dryness is extremely common after any cancer treatment. If you have radiation to the pelvic area and the vagina, it's also common after chemotherapy, especially if that causes a premenopausal woman to enter menopause. And we definitely see it with women using tamoxifen or aromatase inhibitors. The first line therapy for this is vaginal estrogen use. I have a ton of podcasts discussing the safety of vaginal estrogen use. And even ACOG has issued a statement of safety about vaginal estrogen in breast cancer patients since 2013. But still, many oncologists worry about the use of vaginal estrogen in their patients without any good reason or data to support this opinion. I will say, if you are 5 years out from your breast cancer treatment, vaginal estrogen is exceedingly low dose and safe, with no increase in cancer risk or decrease in survival. I've been having the tamoxifen is typically used in premenopausal women with breast cancer, and it blocks the woman's natural estrogen from stimulating breast tissue. We know that with vaginal estrogen, a minimal amount, if any, is absorbed systemically. So if you're taking tamoxifen, then any absorbed estrogen molecule should be blocked by the tamoxifen, and there should be no increased cancer risk. But many postmenopausal women with breast cancer are using an aromatase inhibitor. Those are anastrozole, which is called Arimidex, or letrozole, which is called Femara. These work by blocking an enzyme that converts a precursor into estrogen, so they don't block the estrogen molecule directly. So if a tiny amount of vaginal estrogen is absorbed, the aromatase inhibitor wouldn't see it and wouldn't be able to block it. Now, there's no data to tell us that if using a vaginal estrogen while taking an aromatase inhibitor will change your survival rates or increase your recurrence risk. But I think, again, that the chances should be exceedingly low simply because there's such a minimal amount of vaginal estrogen absorbed into the systemic circulation. Now, one alternative to vaginal estrogen would be to use something like vaginal DHEA, which is branded as Intrarosa. DHEA has to be converted into estrogen within the vaginal cells. So if any DHEA is absorbed systemically, the aromatase inhibitor would be able to block its conversion into estrogen. Intrarosa is a vaginal suppository that's used every day, but unfortunately, sometimes there are issues with insurance coverage and cost. So although it's a great product, you may not be able to obtain it. Lack of libido is the next thing I want to talk about. There's been a little bit of progress in the medical field in the area of women's libido recently. There are currently 2 FDA-approved medications for the treatment of hypoactive sexual desire disorder in premenopausal women. Philbanserin, which is branded as Addy, and bromolanitide, which is branded as Vyleesi. But for any woman noticing lack of sexual desire, I usually don't jump right to medication first. I need to look at the bigger picture. Are you depressed? What's your energy like? What's your relationship with your partner like? I also want to know, what was your desire level before? Is this something that has drastically changed since your cancer treatment? Or was there a slow decline even prior to your cancer diagnosis? Of course, fear of intimacy could be due to pain or dryness, and I want to address that pain or dryness first. But at some point, I may need to offer non-hormonal options to enhance libido. Addy works in the brain to raise dopamine and norepinephrine, and it's been shown to increase the number of positive sexual encounters and decrease a woman's distress over having poor sexual encounters. Since it's only FDA approved for premenopausal women, use in menopausal women is an off-label one. And I've talked plenty about drugs that we use in an off-label fashion. There's a single study of philbanserin used in women with breast cancer, and it did show that libido was improved, but it wasn't a randomized study. So we don't know if the improvement in libido was more than or equal to the placebo. The second non-hormonal treatment for female libido is bromolanitide. That's Vyleesi, and that's a medication that is injected about 20 to 40 minutes prior to sexual activity. So philbanserin is an everyday medication, while bromolanitide is used as needed. Bromolanitide also works in the brain on melanocortin receptors, and it activates certain neural pathways that control mood and thinking. Once again, using bromolanitide in postmenopausal women is off-label, and there are no specific studies for women using it in breast cancer. And finally, we have hormonal treatment of libido. I'm not going to deal with estrogen and breast cancer in this podcast because that could be a whole series of podcasts on its own. And please listen back. I have a great podcast talking about the use of estrogen and its safety. But I did want to address testosterone treatment for libido. Testosterone is an extremely powerful hormone for both male and female libido. We don't have any specific studies about the safety of systemic testosterone therapy in women with breast cancer, but we do know that breast cancer receptors do have androgen receptors. But oncologists don't routinely test for these or report on them. You may have heard that someone had estrogen positive breast cancer or estrogen and progesterone positive breast cancer, but you really never hear if the cancer was testosterone receptive positive or not. There's a good review of androgens in the breast from 2009 showing that if androgen receptors are present on your breast cancer, it's a marker of a less aggressive tumor. It looked at the population of postmenopausal women in the WHI study who received estrogen plus testosterone for at least a year, and it didn't show any significant increase in the risk of breast cancer. And it suggested that adding low-dose testosterone to estrogen therapy may show potential benefits for preventing the estrogen-induced proliferation of breast cells. Probably our largest wealth of information about testosterone and breast cancer comes from Dr. Rebecca Glaser. She did a 2013 study treating both pre- and postmenopausal women with either testosterone pellets or testosterone pellets with anastrozole. She compared the baseline rate of breast cancer, which was 300 cases per 100,000 person years, to the cancer in her pellet-treated patients, which went down to 142 cancers per 100,000 person years. This was after 5 years of testosterone treatment. That's amazing, and that doesn't get well publicized about a possible role of testosterone for reducing breast cancer. And even though it's just one study, and we clearly need more information, it's a very positive and encouraging study. She also published a 2019 study of over 1,200 women receiving testosterone pellets, and there she reported a 39% lower incidence of invasive breast cancer in her pellet patients. So, although we may not have a lot of studies about testosterone in breast cancer patients, there is evidence of testosterone reducing the risk of invasive breast cancer. And I'll link these studies in the podcast notes in case anybody wants to check them out. Finally, I want to touch on pain with sex after cancer treatment, even after the dryness is treated. Sometimes there are still women who have pain with sex, but they feel well lubricated. We really need to get into what is causing the pain. Women who have had pelvic surgery, like a hysterectomy or radiation, may have pelvic adhesions that don't allow the vagina to move and flex and extend during intercourse. These women may need a surgery called lysis of adhesions, where we break those adhesions up. If women have had a type of radiation called brachytherapy, this is a vaginal type of radiation. Radioactive rods and balls are placed inside the vagina to deliver the radiation directly to the cervix or the top of the vagina. This particular therapy can lead to vaginal shortening and scarring. So if you receive this therapy, it's really best to start vaginal dilator therapy right away to keep the vagina stretchy. You can start your vaginal dilator therapy years after your brachytherapy, but at that point, it's much harder because now you're trying to break up scar tissue that's well established. Whereas if you start the dilator therapy right away, you're hoping to prevent that scar tissue from ever forming. And sometimes women have pain with intercourse because the muscles of the pelvic floor have gone into spasm. We sometimes call this pelvic floor hypertonicity. And those muscles can't relax and allow the vagina to expand during intercourse. This is where working with a pelvic floor therapist to release that spasm can be very beneficial. Sometimes we also work with trigger point to whatever treatment option you are choosing. But you do have time to explore all of these post-cancer sexual treatment options and talk more to your oncologist about what life looks like after cancer. And it may involve not just talking with your oncologist, but finding a sexual health specialist or talking to a plastic surgeon about restoring body image. These are all critical parts of your cancer treatment that are just as important as curing your cancer. Thanks so much for listening to today's episode. No information from this recording is intended as a diagnosis or treatment for any disease. If you are enjoying the show, please subscribe so you don't miss any of our exciting episodes. And we love to hear from our listeners and would be grateful for your positive review. We'll talk next time.